Yeah, even at 9:51, there are 215 people on Zoom.
Phenomenal.
Okay, so we are live onto YouTube, and
yeah, I'll just start. Okay, so yesterday we had a session on agonist protocol. So after the agonist protocol, which is quite a longer stimulation protocol, we wanted everyone to know about the antagonist protocol, which is shorter, which is more cost effective, and which is more patient friendly with lesser side effects. So this is, I think, majority of the cycles everyone does now is antagonist protocol, and it's very important. So Dr. Jay will be speaking about antagonist protocol now. Yeah, over to you, Dr. Jay.
Yeah, it's important for everybody to understand that this is the most commonly used protocol as far as IVF is concerned. Across the world, across all IVF clinics, even if people don't understand anything, this is one protocol which you can even copy from somebody else's file, give the exact same dose, okay, do the exact same thing, and you will still end up doing very, very well as far as the ovarian stimulation is concerned. Okay. The other important thing with antagonist protocol, as madam already spoke, okay, is that the good thing with antagonist protocol is that it does not really require a very high dose of gonadotropins which you have to give. Okay, so that is just one thing which you have to keep in mind. The third thing, which is very, very, very important, okay, is that you can use it for all the responders. You can use antagonist for poor responders, you can use antagonist for hyper responders, you can use antagonist for normal responders, you can use antagonist for whomsoever you need to use it. Okay, absolutely, there is no problem. This is one good thing about the antagonist protocol. All right, so I will now switch to the screen sharing, and I will go on to the whiteboard as usual. And Shilpa madam, we would just
yeah, seen.
request you to be there so that this can be seen, right?
Yeah,
so fine. Okay, so we are going to be discussing about the antagonist, and in order to discuss the antagonist, just like last time what we did, we just showed how a normal stimulation would be. So basically, if I look at the ovary here, and when I draw the corpus luteum, okay, if there is no pregnancy which has occurred in the previous cycle, then approximately on day 2021, okay, which we can call as the late luteal phase, there is going to be no HCG to support the corpus luteum. Now, because there is no HCG, there is going to be degeneration of the corpus luteum, and this will allow for an increased FSH in the late luteal phase. This increased FSH will try to ensure that there is a recruitment of a cohort, so that when the patient gets into menses, when we are looking at day 2 and day 3, we have a cohort something like this, which we normally see in an ovary. Okay. Now remember, not all the situations this is going to be a synchronized cohort. This is just going to be a cohort which is going to be present. This can be a cohort which can be synchronized or which can be asynchronized. But usually this is what we report as antral follicle counts. Antral follicle counts are usually follicles which are going to be approximately 3 to 5 millimeters in size. All right. We will talk about the variations a little later. When we look at antagonist protocol, the good thing about the antagonist protocol is that when the patient has turned to you, to your clinic, let's say on day 2, on day 3, on day 4, you are going to have this match of oocytes which you are going to see. One is like this, one is small, one is big, one is like this. But all these guys are going to be at this range, okay, 3 to 5 millimeters. On any one of this day, you can start administering the patient with gonadotropins, okay, irrespective of what responder they are. So these gonadotropins are typically going to be your HMG, but there are going to be some people who like using REC FSH plus REC LH. I'm not going to talk about that in detail. I'm going to talk that HMG is the standard gonadotropin which we use here. So this can go on for approximately 5 to 6 days. Now, when this goes on for approximately 5 to 6 days, what typically happens is that these follicles will be larger in size. And when the patient comes to you, there is going to be a cohort of follicles where most of the follicles are going to be between 9 to 12 millimeter. Okay. When your lead follicle approximately reaches 12 millimeter or on the 6th day, okay, whichever you want to use. Okay. So this is something called as a fixed protocol, and this is something which is called as a flexible antagonist protocol. You wait till 12 millimeters, or irrespective of what it is, you start it on the 6th day. People would start adding antagonist. Okay. Now, why is it that you have to add antagonist? Okay, what is the purpose of adding antagonist and what is antagonist? Let us just discuss that for the time being. So, what does it antagonize? Okay, it is basically a GnRH antagonist. It is obviously synthetic. Okay, two molecules are available: ganirelix, we all know this, and cetrorelix. Okay, both are available. Both are equally good. Both are equally good. It's completely up to you. Which one do you want to use? Do not really go by that thing that nay, you know, this is better than that, that is better than this is better than that, that is better than this. Please don't look into it. Enough studies have proven that these two guys are equivalent to each other. Okay. So whenever, let's assume what I do is I do this, I start it on the 6th day, irrespective of the size of the follicle. What this guy goes and does is it goes and binds to the GnRH receptor. Where does it go and bind to the GnRH receptor? It goes and binds to the GnRH receptors, which is present in the pituitary here. So it will go to the pituitary and it will go and bind to this GnRH receptor. Now, this binding to the GnRH receptor, which the antagonist does, is a competitive binding. Okay. Who is the other person who wants to come and bind to this receptor? You know, the person who wants to come and bind to this receptor is basically a GnRH releasing hormone, gonadotropin releasing hormone. So this gonadotropin releasing hormone name itself says that it wants to go and it wants to release FSH and LH. Right? It is a GnRH, gonadotropin releasing hormone. So it wants to go there, it wants to bind to this receptor and ensure secretion of FSH and LH. This LH is your problem. You do not want a premature LH. This is something which you do not want. You do not want a premature LH. So you do not allow the gonadotropin releasing hormone to go and bind only. Because it does not go and bind, irrespective of the LH what is present, there is going to be no premature LH surge. And this will allow these follicles to then grow into size of approximately 17 to 18 millimeters. Okay. And when these follicles grow up to 17 to 18 millimeters, now you have a beautiful choice. Now you can either give HCG trigger or you can give GnRH agonist trigger. Okay. Or you can give dual trigger in this situation. Okay. All the three are equally good, but as we have discussed in my lecture on triggers, I use the dual trigger. In most of the situations, this allows for excellent quality of metaphase 2 oocytes. This allows for excellent quality of TQEs, that is top quality of embryos. However, when you do something like this, the best is to opt for frozen cycles. Okay, freeze all cycles. There are some people who want to do a fresh cycle with antagonist, especially for international patients. In them, the trigger of choice is going to be giving HCG and nothing else but HCG. Do not give anything else but HCG. The dose of dual trigger has been standardized. The dose of HCG is standardized. We have a 10,000 0.3 for antagonist. When you want to give dual, you just add 10,000 plus 0.3. Do not try to use your head as far as what will going to happen what time. Okay. Lot of times in these type of situations, after you have understood this, as far as the antagonist protocol is concerned, there are going to be a bunch of other questions which people would normally ask. Okay. The first question which people ask is, I have given antagonist at Friday night. Reverse. I have given antagonist at Friday afternoon. The patient is going to come to me on Saturday, and Saturday night I plan to give trigger. Do I need to give an antagonist on Saturday morning or not? That is the commonest question which people ask as far as this is concerned. The answer to that question is very, very straightforward. Kindly don't give. Okay. Kindly don't give. Okay. The reason is, once it dissociates from the receptor, it will cause that rise in LH. That little rise in LH is beautiful for the final maturation of the oocyte to occur. Okay. Even if you don't do it, it is absolutely okay. Your trigger will take care of it. But that final rise in LH, which occurs naturally, endogenous rise in LH, is something which is very, very good in order to ensure a good quality oocyte. Okay. And that is something, just try doing that. Just on the day of giving the trigger, don't give the antagonist. And you will see that endogenous LH forms beautiful top quality embryos. This is purely related to the physiology of the ovary. No rocket science behind it. Okay. A lot of people would ask this question, that in an antagonist cycle, can we give pre-treatment antagonist, right? So the pre-treatment antagonist can be beautifully given in an antagonist cycle. Should you have an asynchronous cohort? We have already discussed this, so there is no point in discussing this. Sometimes people are very fussy between the time interval between the antagonist and the trigger. Okay. So remember, it can be anything from approximately 14 to 30 hours is fine. The competitive binding would usually stop by around 20 to 25 hours. Okay. That is why I said that last 4 hours will cause that small endogenous LH peak. Okay. And this endogenous LH peak is going to allow you to form beautiful quality of embryos. Okay. It is also important that a lot of people are very worried that if on that day, if I forget to give antagonist, it will cause a premature LH surge. Okay. Remember, it cannot cause a premature LH surge like this. For a LH surge to occur, it ideally requires you to have a very strong pulse of estrogen, which is not going to happen when you are using an antagonist protocol. You want to completely avoid that. Whatever HMG, REC, FSH, whatever you are using, start using Letrozole 2.5 with that from the first day of stimulation. Day 2 till the day of trigger, bindas. Okay. What will happen is that will reduce the estrogen, and any which ways, even if your antag to trigger interval is more than 30 hours, it will not cause a premature LH surge. So don't worry about it. Okay. Next, very commonly, people are worried that when I use an antagonist trigger, when I use an antagonist protocol, I will have reduced number of oocytes, I will have reduced follicles, and I will have reduced embryos because one research paper showed it. Believe me, the outcomes are absolutely the same as far as normoresponders are concerned, as far as PCOS patients are concerned, and as far as poor responders are concerned. Yes, there is an issue of asynchronization, especially in poor responders. And a lot of time people are worried that when I start the antagonist protocol, if at all there is an issue of an asynchronous cohort, what do I do? We have mentioned this, so I'll mention it again. Do serum estradiol. If estradiol values are less than 50, okay, even if the lead follicle is 11 millimeters, you can go ahead and start the stimulation. Just aspirate that follicle. If you are scared, give the antagonist pre-treatment and start the stimulation. Okay, nothing is going to happen to anyone. Second, antagonist is not a very long cycle. Your stimulation will actually finish in 9 days. Try calculating it. On the 11th day or on the 10th day, you will be doing your oocyte pickup. in an antagonist cycle. Plus the dose of gonadotropins is less. Okay. Just in case you have to add 1 to 2 more days, it doesn't really matter in an antagonist cycle. But please remember, don't cause an iatrogenic poor response in an antagonist cycle. Okay. Don't start with step up protocol. I will give 150 units only because journal mentioned it. Journal is not going to come and save you. Okay. Start with a proper dose, 300, 375, no matter what you like to use, but start with a proper dose. Okay. Of course, 600 is not indicated, but anything between 300 to 375 is a good dose to start as far as antagonist is concerned, to get a good number of oocytes, to get a good cohort getting streamlined in normal responders. All right. Apart from this, a lot of people are also worried that after trigger, at how many hours should be an egg pickup in an antagonist cycle? So remember, anything between 35 to 36 hours is good. Okay. When you are a busy IVF clinic, if you are doing 10 pickups in a day, sometimes it is going to happen that one pickup is going to be at 36.5 hours. It is no problem as far as antagonist cycle, as far as any cycle is concerned. There is no rupture fixture, nothing like that happens. Don't worry about it. Don't try antic things like giving ibuprofen, paracetamol to prevent rupture on that day. Don't really do these type of things. Those type of things really don't happen. Okay. And finally, before I conclude and start answering questions, look, I have facility to do in-house pathology. So I normally would do an estradiol level at the time of starting any stimulation. I have told this multiple times. If the estradiol is less than 50, I start the stimulation bindas, no tension. I monitor estradiol levels in an antagonist cycle, usually on the 6th day and the 9th day. Again, because I have the facility to do it. Okay, I can get the estradiol report very, very fast, and I normally do it. My antagonist is always going to be on the 6th day. It is always going to be 0.25 only. Okay, single shot, nothing more than that. I don't do LH levels in an antagonist cycle. It is not indicated to do LH levels. It is absolutely not indicated to do LH levels. Even if estradiol level is more than, let's say 300, 3000. Okay, or if it is 2000, or if it is 1800, or it is 5500, for 98% of the patients, the trigger which we give is a dual trigger only. Okay, we have standardized it to become a dual trigger unless it is a very poor responder patient. So what it does is there is no confusion amongst the nursing staff as to what estradiol level, what trigger to give. Okay, for the nursing staff, it is standard estradiol level. If nothing else is written, if only trigger is mentioned, it is dual trigger only. Understanding this is for my hospital. There are people who are going to break 6 hours a day deciding what trigger they want to give to a particular patient based on particular estradiol. We are very happy. Let them continue to do that. But for busy IVF clinics, standardization is much more important than theory. Okay. So with this, antagonist as such would conclude, but this is something where people may have questions. The most common questions which people have asked me, I think I have already answered. But if there are more questions, then we'll ask Dr. Shilpa to ask me 5 questions, and then we can close the session and rest of the questions on WhatsApp.
Okay. So have you used double dose of trigger anytime?
I always use dual trigger, madam.
No. Sorry, not trigger. Sorry, double dose of antagonist. I'm sorry.
I use double dose of antagonist, especially in cases of random start protocol, but that is in pre-treatment antagonist, not at the time of the stimulation.
Not the standard day 6.
No, that is 0.25 only.
Okay. So what about the flexible protocol? I mean, were you using it before when the lead follicle was like 14 mm, 13 mm, and then changed over to the fixed protocol? So have you ever done it?
No, I have always used the fixed protocol because I am somebody who believes in standardization. Okay. The reason why I'm telling this is it is very, very tough. The minute you cross 30 IVF cycles in your center, it is very tough to go and do ultrasounds for all patients on your own. You really don't know if the 12 millimeter which has been written by an assistant is actually 12 millimeter, or is it 13 millimeter, or is it 14 millimeter, or 11 millimeter. Okay. So no point looking into it in micromanagement. Day 6, start antagonist. Close your eyes like that.
Okay. And on the day of antagonist that you start, do you increase the dose of gonadotropins or
No,
it's
no. The dose of gonadotropins would stay the same. There is no need to increase the dose of gonadotropins. Rather than doing that, start with a higher dose to start off with. The higher dose in the first 5 days will allow recruitment of more follicles, then increasing the dose on the 6th day once the recruitment is already done.
Okay, so let's see, since you are doing majority freeze all, so it works for you to freeze everything, and that's why you give the dual trigger also. But people doing fresh transfers, like in maybe like, low ovarian reserve patients who we expect 1 or 2 good embryos to form, and if we are expecting to do a fresh transfer. So in such cases, we still recommend higher dosage of the HMG to be started, or it depends on various factors like age and all sorts of things that we take into consideration and decide on that.
If in case you want to standardize the dose, then the standardization of the dose should be at 375 international units of HMG, irrespective of the responder. Okay. There you may end up calculating based on age, weight, BMI, all these things. But if you want to standardize the dose, one dose which will fit into almost every basket, then it will be 375 international units. You can try doing that and you will see over the next 10 patients that it will work very nice.
Okay. And what about the luteal phase support in case if you're doing a fresh transfer in antagonist protocols?
In fresh transfer in antagonist, trigger is always HCG 10,000. That is the first thing. Second, always add estradiol valerate in fresh transfer for luteal phase support, or estradiol hemihydrate and vaginal progesterone gel. Okay. The choice to add dufastone or to not add dufastone is on the fine sense of wisdom of an individual consultant. Even if you add, it is okay. Even if you don't add, it is equally okay.
Okay, so here is a patient who you're not sure whether you're going to freeze all or you're going to do a fresh transfer. So in such a case, like what are the parameters that you consider? I mean, do you fix each patient beforehand, counsel them that you are going to have a freeze all cycle, or it is like as the stimulation goes on, then you decide whether it is
No. So only patients who are undergoing a fresh transfer, they are the patients on whom our file will have a code that this is a fresh transfer patient. Everybody else is freeze all only.
In all your cycles, 150 cycles, I mean, you are going
in all cycles. In all cycles.
In that many, how many you would have a fresh transfer roughly in your setup?
Approximately 7 to 8, because these are going to be all those international patients who are in India for a very less period of time.
Okay, so in fresh transfers, you are going to consider like, the E2 levels or the number of follicles, or what is it that you take into?
So we, as I said, we normally will always also add letrozole for all fresh cycles, for all FET cycles. Okay. What this does is, this does not really cause a supraphysiological elevation of estradiol. If you ever measure estradiol levels in a stimulation where letrozole has been added with HMG or recombinant FSH or whatever you want to add, you will see that even if you have 10 good follicles, estradiol will be around 400, 300, something like that, 500, whatever. In this type of a situation, your output to maintain synchrony with the endometrium will be very, very excellent when you have added letrozole, and you can do a fresh transfer by giving an HCG 10,000 trigger should that patient have opted for fresh transfer. Okay. There are very few cases where we will not add the letrozole. The reason why I'm answering this is because you are saying how much estradiol will we look at even while doing a fresh transfer in an antagonist cycle. Okay. So there will be very, very few such situations. One of the situations is AFC less than 5, which we have. So we have formalized even that if antral follicle count is less than 5, don't add letrozole. Okay. Straight HMG. Anything more than 5, 8, 7, 6, 20, 60, 50, 40, add letrozole plus HMG. Simple. Okay. So there is no confusion between any sonographer who is coming in to decide what we are supposed to do. And there is no confusion in the nurses as well to add letrozole, stop letrozole. No such thing can happen.
Yeah. So, do you believe in giving at least 8 days of stimulation and then only are you going to give the trigger? I mean, do you believe in that concept, or it's even if it is like 7 days of stimulation, if the follicle is like?
Listen, as long as the follicle has reached a particular size, okay, there are only two options that follicle has. It is either a follicle having an oocyte or it is an empty follicle. Correct? At a particular size, the reason why it has reached that particular size is because the amount of secretion from the granulosa cells which has gone inside. Okay. This secretion from granulosa cells never increases. It is the granulosa cells which increase. Okay. There is high multiplication of the granulosa cells. As a result of which, once you have a particular size, that many receptors will be formed on every cell. So if you give a trigger beyond 18 millimeters, between 18 to 21 millimeters, the number of receptors over that follicle is very good. And even if it is 5 days of stimulation, okay, even if it is 5 days of stimulation, you will get an oocyte out of it, as long as it has developed that much maturity. Okay. The only condition where you will not get it, is if it is a pre-existent follicle, which is 11 millimeter in size, because it was any which ways an empty follicle which did not resolve completely, or it was an apoptotic follicle which took some, FSH search from somewhere and developed that size. It will increase in size, but it is any which ways not having an oocyte inside, so that will not give you an oocyte. For every other small follicle, that 2 to 5 millimeter follicle, which has grown from 2 to 5 to become 17 to 18, 19, whatever, you will get an oocyte as long as there is oocyte inside it.
Okay. Do you believe in coasting? I mean, do you do it? Do you reduce the dose?
No coasting.
Okay. And
give dual trigger. What coasting? If you are worried about coasting, give GnRH agonist trigger and freeze all. Why should you do coasting? Coasting is not done. I mean, even Gardner would have stopped doing it by now, I think.
Have you ever done this day 2 stimulation antag? Have you tried it?
Day 2?
Day 2, yeah. Day 2 of stimulation, they start antag and then they continue. This is only 2.
So that is pre-treatment antagonist, right? Day 2, day 3, you can give pre-treatment.
No, that's continuous. Day 2 of stimulation, you just
give so from day 2 till this thing, right?
Hmm.
No, I have not done that. Nor do I plan to do that.
Okay. Yeah, I think I'm done. So I'll just check in this thing. So you only do the
HMG. So one question which I want to answer is, it is not day 6 of menstrual cycle, it is day 6 of HMG stimulation. Okay. Yeah, that's when we add antagonist on the fixed protocol.
So you only do the HMG cycles, right? You don't use the Recomb FSH at all in your center.
Stopped using it since 5 years.
Okay. So letrozole is 2.5 mg from the day of
2.5 mg. Yeah. From the day of stimulation till the day of trigger.
Okay. So you give antag in the mornings or in the evenings? Somebody is asking.
Doesn't matter. Give when you want to give.
So do you give them together? Should there be any time interval where you have to maintain between the gonadotropin and between the HMG and the antag?
Give HMG on the hand, antag on the stomach.
And you use GnRH?
Sorry?
GnRH or GnRH as?
I have used both, but these days I am using GnRH. Yes, Kiran sir. What did you want to ask?
Yeah.
No, there's a question wherein it's asked, you give antag and trigger at the same time. Dual trigger, do you give at the same time? Dual trigger
at the same time.
At the same time.
Same time. Yes, absolutely same time.
So progesterone level or unless it is a fresh to do it?
I lost your voice completely.
I'm sorry. Do you do progesterone levels on the day of the trigger?
If you're wanting to do a fresh transfer, then yes. If on the day of trigger, your progesterone value is less than 1.25, it is good to go ahead with fresh transfer in such type of cases. If you want to, huh?
We are done. Okay. Yeah, sure. I think you don't do too many hormone levels in the cycle for the 6 and day 9.
Three times we'll do estradiol level. That is on day 2 of starting treatment, on day 6 and on day 9. Beyond that, we don't do hormonal levels for the patients.
So what is the cutoff level of estradiol on day 6 and cutoff on day 9?
There is no such cutoff. Honestly, to be honest with you, as I said, I use letrozole in a lot of cycles. More than 90% of cycles are with letrozole. Okay. I will give you an example. See, when you are doing oncofertility, we do a lot of oncofertility preservations because we get a lot of referrals from medical oncologists. Okay. So when you are doing oncofertility, you are giving letrozole throughout. You don't stop letrozole at all. Okay. Letrozole is given from the day of stimulation till the end of second stimulation. So you can give letrozole continuously for 30 days. No stopping letrozole in that. Okay. Still the quality of oocyte is fantastic. Still the response to stimulation is absolutely fantastic. Okay. So letrozole is a wonderful drug if you want to add to reduce your estradiol levels and to reduce your OHSS irrespective of the trigger which you give. And I mentioned it in the previous lecture as well, that should you be worried that you have given an HCG 10,000 trigger? No problem. As soon as you finish your egg pickup and if you are doing a frozen cycle, add letrozole on that day. Give 2.5 mg of letrozole for the next 3 days, 4 days, whatever. It will cause luteolysis, you know, and that luteolysis will not cause OHSS, or at least will reduce the severity of OHSS. So you can really try doing those type of simple things.
Yeah. So anything else, Kiran sir? Anything you would want to ask? I'm done.
No, if going in with what you are saying, is it feasible or is it indicated to increase the dose of letrozole from say 2.5 to 5 milligram just to reduce even the measurement of serum estriols?
Why to do that? See, honestly, this actually 2.5 mg of letrozole is a very good dose to cause reduction in estradiol. Okay, very, very good dose. Even if the patient is very obese, it is a good dose. Understanding? But if you are using isolated letrozole stimulation, then maybe you can add 2.5 twice in a day. Apart from this, for IVF protocol, well, HFG is being given, no need to make it 5 mg.
Yeah. So I thank Dr. Jay for this wonderful session. I think it was excellent. And at the same time, I would like to congratulate him that the stem cell and hysteroscopic adhesiolysis, which he did,